Hello, PsyQ community, and welcome to today's presentation. This is Stephanie Asper, and today I'm joined by Dr. Fatima Sadat, who is joining us for part 2 of her series of presentations on digital interventions in psychiatry. Today's presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc., and our speaker is a paid employee of OPDC. Fatima Sadat is a medical science liaison for OPDC. She received her PharmD from Touro University in Vallejo, California. Today, Dr. Sadat will be doing a dive into different types of digital technology that may provide tools for the assessment and management of mental health. Without further ado, I'll turn the presentation over to Dr. Sadat.
Thank you, PsyQ community, for joining us today. So we will take a deeper dive into the types of digital technology in mental health. So mental health disorders are a growing global concern, and there's a necessity of developing novel services and researching effective means of providing interventions to sufferers. Such novel services could include technology-based solutions already used in other healthcare applications, but have yet to make their way into standard psychiatric practices. We will look at digital technology that may provide new tools for assessment and management of mental health. So let's start off by looking at mobile health sensors. Currently, there's a wide range of sensing techniques used especially in wellness and health monitoring applications. Mobile health, or M sensors, are convenient since most people own a cell phone and can monitor several behavioral indicators of mental health. And there's a widespread use of digital devices in the seriously mentally ill. A 2014 survey of psychiatric outpatients across 4 U.S. study sites found 86% had a cell phone, and most of them being smartphones. Wireless sensors can be worn, so wearables, or carried, such as portables, such as cell phones, during normal daily activities for monitoring health status. And technologies can include implantable or ingestible sensors as well, and deployable sensors that can capture data from the environment. For example, if the patient is in bed or out of bed or is around the house or at other locations. So currently, clinical psychiatry relies greatly on the retrospective self-monitoring of patient symptoms. These methods of data collection, whether it's at the end of the day, a paper diary, or a simple interview or a structured questionnaire, have one common feature, and that is the information must be relied from the patient's memory. This can lead to misjudgment from the patient's end, and studies have actually showed that gathering information retrospectively is subject to multiple biases. It's also known that positive events are more likely to be remembered than ones with negative association for the patient. So the processing of memories is also connected to the current mood, which introduces even more variability to the recollection process. So wearable sensors placed on different parts of the human body can capture in-the-moment information and can help minimize recall bias. So it can look at things such as change in skin conductance, changes in heart rates or blood pressure, motion detection, online and mobile interaction. And ambient sensors can be used to track activities of daily living, such as, for example, if pill bottles or containers are open and closed, and infrared sensors can be used to detect activity or movement in a patient's home. Optimal mental health care is dependent upon sensitive and early detection of mental health problems. Smartphones and many wearables are able to collect data such as location via GPS sensors and voice data from conversations and social metrics via calls and text logs, all without the user taking any additional action. These advancements in mobile software and hardware are enabling collection of an abundance of data that until recently were completely inaccessible to clinical researchers and practice teams. Future predictive modeling implemented in mHealth applications in real time may be able to assist clinicians in identifying the start of symptom decline and relapse patterns earlier than previously possible. Next, we will take a look at digital interventions and assessment. So presented below is a snapshot of literature evaluating how technology can be used to deliver psychosocial interventions in patients diagnosed with serious mental illness. And we look at each disease state specifically. So for major depressive disorder, a pre- and post-treatment study evaluated therapist-assisted internet cognitive behavioral therapy in a clinical setting, The trial included patients diagnosed with major depressive disorder, about 83 patients, as well as patients diagnosed with generalized anxiety disorder and panic disorder. The cognitive behavioral therapy intervention consisted of 12 online modules, which were primarily text-based with psychosocial education and cognitive behavioral therapy-based strategies. Patients completed an average of more than 8 of the 12 modules with an average duration of about 127 days. Program satisfaction was fairly high, averaging about 5 on a scale from 0 to 7, with 7 being very much so satisfied. Bipolar disorder is also looked at here. A randomized study compared 2 10-week self-help online interventions. One included text-based psychoeducation and small group online discussion boards. The other also incorporated interactive cognitive behavioral therapy-based tools. 48% of these participants across both arms completed all 5 modules, and non-usage attrition rates was comparable to similar self-guided online programs. Schizophrenia is also shown here with a pilot study which evaluated about 10 sessions of self-directed interactive online cognitive behavioral therapy for coping and auditory hallucinations. And we see that 16 of the 17 participants completed all 10 sessions, and 82% of respondents reported that the program was very good and helpful. For first episode psychosis, a 1-month pilot program evaluated social therapy based on online interventions designed specifically for young people with first episode psychosis. And we see that no dropouts in the pilot study, and 60% completed at least 3 therapy modules. So as seen from the examples listed above, attrition and satisfaction are common endpoints in the evaluation of technology-based applications. This is because participants stop usage and or being lost to follow-up is a key characteristic and challenge in the evaluation of technology-based applications. On the following slide, we will take a look at clinical decision systems. So the use of clinical decision support systems, or CDSS, to facilitate the practice of evidence-based medicine promises to substantially improve healthcare quality. The Institute of Medicine has long recognized problems with the healthcare quality in the United States, and for more than a decade has advocated using health information technology, including electronic CDSS, to improve quality. These systems are mostly computerized, although traditional paper-based algorithms and treatment recommendations are also considered in clinical decision support tools. Computerized CDSS are software designed as a direct aid to clinical decision making. These systems match an individual patient's characteristics to a computerized clinical knowledge database, and patient-specific assessments or recommendations are then presented to the clinician. By providing current evidence-based, patient-centered information to assist in clinical decision-making, CDSS may help to reduce the inference gap. So CDSS can provide support throughout the stages of the healthcare process, from preventative care and patient assessment to diagnosis and treatment, and then monitoring and following up with these patients. Here we look at examples of potential CDSS interventions, including screening as part of the patient assessment and preventative care, guideline recommendations when making treatment decisions, drug-drug interactions, and alerts when prescribing medications, and algorithm-based recommendations as structured care protocols, as well as follow-up reminders during the monitoring period. So CDSS can provide support to clinicians at various stages in the care process, from the preventative care that we talked about to the treatment, to monitoring and follow-up. So the rapid growth in the use of mobile phone applications or apps provides the opportunity to increase access to evidence-based mental health care. So let's take a look at the mobile apps for mental health. So here we take a look at definitions across mental health or mobile health. So mHealth or mobile health is defined as a medical or public health practice supported by mobile devices, such as phones, patient monitoring devices, PDAs, or wireless devices. A mobile application or mobile app is a software that supports it and can be run on a mobile platform. So it can, for example, it can be a handheld commercial or off-the-shelf computing platform with or without the wireless connectivity. And then we have mobile mental health, and this is the use of mobile devices for the mental health monitoring, and management. Here we take a look at some popular features of the mental health apps, which are shown and can include medication reminders or use of the apps to develop tools for managing stress, anxiety, or sleep problems. Clinical practice guidelines recommend cognitive behavioral therapy and self-help resources such as mHealth as options for psychological treatment for individuals experiencing mild to moderate symptoms of anxiety or depression. mHealth apps can be used as standalone self-help programs or in conjunction with treatment modality in guided programs, for example, part of a website or through direct contact with mental health professionals. The app can include treatment components such as cognitive therapy, behavioral activation, psychoeducation, or monitoring of symptoms. Skills training apps may feel more like games than other mental health apps as they help users learn new coping or thinking skills. When we look at illness management, we see that this type of app technology adds additional support by allowing the user to interact with another human being. The app may help the user connect with peer support or may send information to trained healthcare providers who can offer guidance and therapy options. A lot of effort is going into developing apps that can collect data using the sensors built into the smartphone. These sensors can record movement patterns, social interactions, such as the number of texts and phone calls an individual receives or sends, behavior at different types of the day, vocal tone and speed, and more, with the goal of alerting caregivers when the client needs additional attention. The apps can provide education to patients and also deliver the intervention. We know that adherence is an issue in the seriously mentally ill. One study found that 75% of schizophrenic patients will become non-adherent within 2 years of hospital discharge. So we will take a look at medication adherence technology on the following slide. Here are some examples of adherence technologies in psychiatry. We can see that calendar-based systems are there to alert patients to take their medications at specific times of day. Video chat is available to allow a healthcare provider to directly see if a patient is taking their medication. Maybe email and text notifications can remind patients to take medications or to schedule appointments. We also have smartphone and tablet apps, and this reminds individuals to refill their medications or drop off their prescription to the pharmacy. We know that the seriously mentally ill are non-adherent to their medication, and this is an issue because according to the New England Healthcare Institute, poor adherence to treatment regimens contribute as much as $290 billion annually in avoidable medical costs. What's more is that medication non-adherence is the leading cause of preventable morbidity and mortality. It's thought to account for 30 to 50% of treatment failures and 125,000 deaths annually, according to the American College of Preventable Medicine. With the promise of digital technology, it could help change this trajectory. Therefore, a lot of technologies on adherence are focused on medication adherence, such as smart pills equipped with sensors. We have facial recognition, breathable devices where a patient blows into the device to see if the medication has been ingested, smart packaging that looks at if the pill bottle has been opened or not, wearable devices, and voice recognition, which can request medication refills to the pharmacy. Telepsych has become more widely available and can help provide mental health services to more individuals. We'll take a look at telepsychology and psychiatry on the following slide. So telemedicine is the process of providing healthcare from a distance through technology, often using video conferencing. Telepsychiatry is a subset of telemedicine and can involve providing a range of services, including psychiatric evaluations, therapy, and this therapy can be individual or in group or in family therapy. It can also include patient education and medication management. Telepsychiatry can involve direct interaction between a psychiatrist and the patient. It also encompasses psychiatrists supporting primary care providers with mental health care, consultation, and expertise. Mental health care can be delivered in a live interactive communication. It can also involve recording medical information such as videos and images and sending this to distant sites for later review. So telepsychiatry was originally conceived to enhance access to remote and rural populations to specialized mental health services. Over the last 6 decades or so, a growing body of evidence and increasing implementation has demonstrated that telepsychiatry's ability to provide mental health services which are accessible to a wide-ranging and high quality of care. Telepsychiatry can also offer services such as development of clinical care plans, case management, crisis intervention, neuropsychological testing, legal aid, forensic evaluations, liaison services for other medical specialists, and nursing care. Telemental health is used routinely to give people access to educational events from remote locations. It can serve as a platform for net-based distance learning and sources such as webcasting. Finally, a variety of administrative and managerial functions can be supported by telepsychiatry, helping in reducing the cost, time, and travel involved in carrying out these tasks. The setting in which these services can be delivered are equally diverse. They include inpatient, outpatient, emergency services, forensic settings, community settings, nursing homes, assisted living facilities, prisons, schools, and homes of the users. The patient population can vary from children to adults to the elderly and to special populations such as prison inmates or military personnel. Professional users can include all manner of mental health professionals, such as local psychiatrists in training at distant sites, nurses, health workers, and educators. So, of course, there's advantages and limitation to integration of digital technology and psychiatry, and we'll take a look at this on the next couple of slides. So, digital technology-based assessments interventions offer several potential advantages, such as increased access to psychosocial interventions, reduced resource intensity, tailoring to the individual, and convenience of administration. However, this is balanced out by some of the negatives that are shown here, such as long-term adherence to the use of these devices is really unknown, and the cognitive impairments that some of our individuals with serious mental illness face can also inhibit them from using these devices. And also, what if these devices are lost or technical problems exist for some users? So there definitely is pros and cons to each side. So here we look at some of the barriers, and there are quite a few. For example, lack of trust from maybe the patient or the healthcare provider as to where this information goes, and that leads to privacy and security concerns, maybe regulatory concerns. How usable is this interface? The lack of infrastructure or the lack of engagement, and not only the lack of technology that maybe that the patient might see, but also the lack of knowledge and technology from the healthcare provider's point of view as well. So definitely a lot of barriers to overcome when we're using digital health in the space of mental health for patients with serious mental illness. Thank you so much for joining us for Digital Interventions in Psychiatry Part 2. My name is Dr. Fatima Sadat, Medical Science Liaison with Otsuka Pharmaceutical. Please check out our website for more information on digital psychiatry and more.